So firstly, my name is Tina Prenteville. I'm the lead midwife for North Thames. This is my colleague Liz Bancroft, who's the chief nurse. And on behalf of the North Thames Genomic Medicine Service, a very warm welcome to our preconception event today. Our lineup of expert speakers will be talking to this critical phase of reproductive health, despite, as we know, there being very little provision for it in the clinical space. We also want to raise awareness of the growing potential of genomic medicine and how advances in genomics are enabling earlier identification of risk in pregnancy. This also is supporting research, informing reproductive choices, and driving a shift towards personalised and preventative care. At the same time, we recognise that stark maternal inequalities persist. And today is about changing the momentum, it's about challenging current practice, having conversations about what good preconception care looks like. And so we can take those conversations back to our organisations and our trusts. So we're really happy to have you as part of that conversation today, and we really hope you enjoy a fantastic programme.
And talk to people about preconception. And this study day looks absolutely fantastic. You've got some great speakers. And as has been said, preconception, you don't really, when you're thinking of having a baby, you don't, is that any better? Oh, sorry, it sounds like it's picking up from here, but when you're going to have a baby, you don't really think about what your egg's going to be like and what the sperm's going to be like. Well, I don't think many people do. And I don't think many people think then about what they're bringing to that baby in terms of their genetics. And I kind of say that because colleagues of mine who have had to have IVF, particularly eggs or sperm, either anonymous or known donor, suddenly are asking some of those questions. And some of those questions are asked, interestingly, when you're donating eggs and sperm for conception. But it's not something that is generally, I don't think, thought about by the public when they think about what they're bringing to that embryo and consequently that baby. And of course, again, as has been said, critical to maternity safety and maternity care, preconception care, and the pre-planning. What we do know in maternity care are the health inequalities and disparities, and that Black and Asian women more likely to die from pregnancy-related causes than white women, and much more likely to book late, if at all, so that a lot of the pre-birth care is not possible to deliver to women, and in part, I guess, leads to the rate that you see there, but also to the health and well-being of the unborn child. So a really important, I think, area of focus going forward in terms of promoting health. And of course, those health inequalities across the mums and the baby impact on the family through the generations, but also impact on healthcare going forward because they become then users of healthcare, which is, as you know, a very rare resource. I've been asked to sign in on my slide. Sorry. Thanks. And yeah, so I think in terms of why preconception care, those reasons particularly there. I'm joined today as well by Colette, who's at the back of the room, who's from NHS Genomics unit, and is helping me with a lot of this work, particularly the embedding work. Sorry, I should have introduced Colette at the beginning. There you go. It's a really important area of care, and I think the programme today reflects some of the diversity of care and care considerations, clinical considerations for women, for men, and for families. It's a whole family issue, I think, and a whole multidisciplinary issue across many specialties. It's not just an issue for midwives or for health visitors or for obstetricians. It's an issue across the whole span of healthcare. So we are awash with documents on genomics and accelerating genomics into healthcare, about rare diseases, life sciences, the Embrace report. I've read quite a few of these, and they are quite good reading, to be fair. I wasn't quite expecting Fit for the Future to be so good, and they're usually things, if you've got a little bit of insomnia, you might want to pick up. But having said that, they were very informative and quite short, and also quite easy to skip through. So if you do get a chance, if you're looking at them thinking, oh my gosh, she's not suggesting that I read all of those, how many are there? 8. Do try and skip through them, because I think there's quite a lot of useful information in them. And also they provide, I think, frameworks for practice, which are very, very useful. And those reports will pick out quite a lot, I think, and translate into practice some of the things that you'll hear today. So there are lots of opportunities to get genomics embedded into practice. Many of you, I suspect, here today are experts in the field, and I'm not, and we'll know lots and lots about genomics and how it impacts on care and how it impacts on individuals. But the majority of clinicians, and my medical director would include doctors in that, but certainly nurses, and nurses more so than midwives, because midwifery and maternity care has had many genetic tests in it for many years, will look a bit perplexed when you talk about genomics and healthcare, and look a bit confused and feel a bit fearful, because they'll feel they won't understand it. So I think our job, my job and your job, particularly those of you in specialist areas, is to get that message across to everyone in healthcare in a simple and easily understandable way that means then they can use it in their clinical practice. And bringing those big advances in genomics to the bedside so that we start to transform healthcare, so that we get onto the front foot, particularly with some of the rare conditions, particularly with some of the cancers, but also some of the things like hypercholesterolemia and genetic changes that put people in a very disadvantaged place in terms of their short and medium healthcare and healthcare outcomes. So really important that we start to embed those conversations into our encounters with patients and their families. And someone once likened it to, in terms of what nurses and midwives do and doctors each day in healthcare, when you're taking a history, that's when you start to have those conversations at any opportunity. And again, I think if you can make it simple and make it understandable, then most healthcare professionals will think, yeah, I do that. You'll be familiar with the Genomics medical service delivery model. This is a map where the dark blue, there's a model across the whole of the country that broadly maps to the regional offices, and some overlap with the ICBs, and some overlap with the undergraduate medical training. And though that genomic medical service is to deliver the strategies, the 10-year plan for genomics medicine in this country, with focuses on data, focuses on transforming services, looking at workforce and education, and also science, research and innovation. It's a tall order for them, I think, at the best of times. This is the generation study, particularly relevant today. It's a maternity study. It enlists hundreds and hundreds of newborn babies into genetic testing for over 200 genetic conditions. I think we've got a stand, I think you said there, if you want to know a little bit more about it. Pointing at you, pointing at the stand. So it's a simple blood test that you get enlisted into, and as I say, it will check your baby's DNA for over 200 genetic changes. And what's interesting, and for me a bit about this study, is that as we've done sessions with nurses and midwives to introduce them to genomics and for them to think about it in their practice, we often bring case studies. We've had a number of mums and dads and families come who've had children ranging in age up to sort of 16, 17, who throughout their childhood have not quite been right. That's kind of how they would describe it. And it's caused a lot of anxiety and worry in the family. And as genetic testing has advanced, many of them, well, the case studies we've had that have come and shared their experience, have identified the genetic testing has identified changes and mapped them to what those changes would cause in terms of their personal health. And they go, they're like, oh, thank goodness, we finally know what we can be doing to support our child, to make our child's life better and healthier and help them live a fulfilling life into the future. And I think in that sense, this study is really, really important. The other side of that is if you're a new mum, I'd be thinking, do I want to know? And of course, I'm not going to talk about this in my session, but there are lots and lots of ethical questions about whether you want to know as a mum. Thank you. And indeed, whether the child would want to know or the family would want to know. She's been given the signal to speed up a bit. Help Nursing and Midwifery, Colette and I and one or two others set about a journey of developing a framework for genomics in nursing and midwifery to give a bit of an overview of where we think it is in nursing practice. So in my organisation, I've got really highly specialist doctors, nurses, midwives working in genomics. And then I've got nurses, midwives and doctors right at the other end who would look at me blankly and not really understand how they could embed anything to do with genomics into their practice. So the framework helps to guide people along that continuum to get more knowledge, more skill, more confidence in talking about and signposting genomics in practice. There are a number of actions in it where there's a bit of a kind of call to arms for nurse educators, for operational nurses and midwives, and for the ICB and regional and national nurses and midwives. And Colette and I are working with the Chief Nursing Officer to get some of this plugged into his nursing and midwifery strategy that we're expecting to see sometime this year. And we've tried in that document, if you want a sort of shortened version, to summarise some of those strategic documents. If you don't fancy all 8 of them, just read our first 10 pages of our framework and you'll get a bite-sized chunks approach. It's got 4 key areas, issues as I've talked about around awareness, raising awareness and getting a bit more confidence in the workforce, looking at the needs of the workforce. So what are those people saying that they need to help them get confidence and awareness? We're building the networks that we've already got that I'm sure many of you are part of, and encouraging nurses and midwives to join those networks. And then we've got a whole suite of education and training that the Genomics unit have worked on, which is excellent and free. It is online. Sometimes, it's face-to-face is maybe better, but it's excellent education materials. So if you haven't looked at it, look at it. And if you haven't shared it with your colleagues who know less than you, then point it out to them. So we know, this is illustrative, I guess, of the touch points for nurses and midwives in the genomics journey. We know there are lots and lots of touch points, from offering a test, getting the results of the test, relaying back the education and training around the test, supporting the patient and their family with the test. And there'll be no one in this room, and generally there's no one in any room that Colette and I or out in clinical practice have groups of staff and talk to, that when you say, have you taken a history? Have you talked to anyone who's had breast cancer? Have you talked to them about the genes that might be passed on for breast cancer or hypercholesterolemia or a whole raft of other conditions? Don't go, oh yeah, I've done that, I've been involved in that. And those are really important conversations to start to have, because one of the big, I'll come back to that in a minute, one of the big issues for me is that if we get this right, we'll get the right care to the right patients at the right time. And that actually is cheaper and more efficient. So we won't be putting people through very extensive chemotherapy that doesn't work for them. and making them feel really ill and putting them through a lot of stress and pain, and their families through lots of stress and pain. We can target and personalise, as has already been mentioned, the care and treatment for patients going forward. And that will keep them healthier longer, saves money, makes us more efficient and productive, and it will save on the treatments, because we will not be giving lots of treatments and care that won't work for patients and their families. And that precision and that personalisation, you know, is advancing at a really, really rapid scale. I've got hypercholesterolemia in my family, and you know, when my twins were they're 20 now, when they were 8 or 9, we were thinking, I'm going to have to get them tested. And then ping, into my inbox came a note from the GP practice. So well done, my GP practice and the practice nurse, that said your children need to come for a blood test. I thought, wow, that it's working, it's working. What was really interesting was my children's reaction. They knew it was in the family. And they were very worried about going for that blood test and very anxious about the outcomes of that blood test, even at that age, which I kind of should have anticipated, but, you know, sort of slightly typical nurse, really. Let's get on and get a test and then we'll get it sorted out. For us, both of them came back not with hypercholesterolemia, but it made me feel really pleased that primary care were on it. My GP practice were on it, but it really gave me an insight into how the family dynamic and how the children felt about going through that process. And the outcome for my partner was that they were popped on statins at 9 or 10. But that was good for my partner, because on that side of the family, everyone else, if you go back a few generations, had died between sort of 50 and 60 from heart-related conditions. And that long ago, they didn't really know why that was. It was, oh, well, the men had dropped dead from a heart attack. So very good that we got that call, we got the health check, we're fine. But frightening for the children in particular, I guess. We felt we knew probably a bit more about it and the benefit of doing the test. So that it's not as simple as do the test and let's see what we've got. There are a whole raft of emotional and psychological aspects for people about that I'm sure many of you know about. These are the links to the education and training. I've got a minute left, so I'm sure these slides will be shared and you can get straight in and have a look at those through those links. Yeah, and the big message is think about where genomics applies to you in your practice. So looking around the room, I'm absolutely confident that most of you do every day, but a lot of nurses, midwives and doctors, AHPs don't. So it's really the challenge is to get everyone thinking about it. If you say, like I do, how many of you got breast cancer in the family? How many of you got hypercholesterolemia? Yeah, a lot of hands go up, and many, many more of us, I think, have been affected in our personal lives by genetic testing. We might not realise that was what it was, but many of us will have been. I interestingly also have Dupuytren's contractures in my hand, and off I go to our orthopaedic surgeon. He said, "Oh, it's hereditary." I said, "Really?" So I go to my mum, my good northern mum. "I didn't give you that," she says. And there she is sat with it in the same hand, and it's bad in the same hand. "I didn't give you that." I said, "Well, I think you might have done, Mum. It's genetic." No, not from my side of the family. So I left it there. I thought, no, park that. So thank you. I hope that was helpful. As I say, spread the message. Have a great day with looking at the preconception issues. I know you've got cardiac diabetes and a whole raft of people coming. It looks like a great day. And thank you.
Today. So our second speaker, unfortunately, just caught up on the train, which will be here shortly. But Professor Jenny Hall has offered to go next on the agenda. So it's my pleasure to welcome Jenny. She's a Professor of Reproductive Health at UCL Institute for Women's Health and also Co-Director of the NIHR Policy Research Unit in Reproductive Health. And Jenny is internationally recognised for her work in reproduction health, preconception care and public health,
particularly measuring pregnancy intention and improving outcomes for women worldwide. So it's my pleasure to welcome you and thank you very much. And if you can use the microphone, and Dom has got a little bell that he's ringing when people are getting close to time. So thank you.
Thank you. So I just
so yes, it's just oh, actually, that's.
And thank you for the introduction. And like Janice, I'm also getting used to a new title, so it still feels a bit strange to be introduced as a professor. But we're trying to grow into it. So as she said, my background is as a public health doctor. So I come to preconception health thinking more about a public health and a population lens. So I'll try and bring a bit of that to the presentation. I'm going to tell you a little bit about a group called the UK Preconception Partnership, a bit about who we are and what we do, a little bit of background into preconception health. We're all here because we're interested in that, so I won't dwell on that too much. And then I'm going to talk you through a toolkit that we put together last year and some of the information that's in it. And then, given the focus of today, I'm going to talk very briefly about some expanded carrier testing work. It's not my work, so don't grill me on it, but I just wanted to bring something to the table in terms of the genetic side. And then I will be around for the morning, so I can answer any questions or have a chat. So thank you.
Speaking to that.
Sorry to get back. All right. Okay, so
I think it's a side highlight.
Thank you. Okay, yeah. So the UK Preconception Partnership, we set up this partnership in 2018. The same time we published the first 3 papers in the Lancet that were the preconception series, and it was really at the beginning of getting preconception health on the agenda. Oh, what a mind zone. And the partnership is a grouping of basically anyone who's interested in preconception health. It's individuals, it's organisations. There are the various royal colleges and faculties on there. Tommy's is on there. Clinicians, academics, charity policy, all sorts. Basically, anyone who's interested, it's free to join. We have 2 meetings a year that are hybrid, usually online, occasionally hybrid, where we talk about important things that are happening in preconception health. And it's been a really important organisation or grouping for raising awareness, for working with policymakers. So we have submitted evidence to consultations. Our members sit on advisory groups or task forces with government organisations to try and get preconception up the agenda. And the vision is about supporting preparation for pregnancy and parenthood. So if you use that QR code, that will take you to our website. There's a lot more information on the website about who we are and what we do, and links to various publications and so on. But our vision is about a society where preparing for healthy pregnancy and parenthood is a routine part of life. So something that is normal. Conversations about this happen in healthcare, in other settings, unlike what the current situation is. We think about the healthcare and environmental conditions. So it's not just about individual people and their individual behaviours, but thinking about the wider determinants of health and that public health perspective to preconception for everyone. And also thinking about inequalities in health outcomes. So just to set the scene a little bit about what constitutes preconception care and how much of a need there is for it. So we often think very much about the individual in front of us if we're in a clinical situation, that person's particular lifestyle factors, pre-existing conditions, genetic status perhaps. But from the partnership's perspective, that is just one part. And we've also got to think about the societal factors. So if they're in a relationship, what's that relationship like? The sort of family setting, the community setting, the support, any issues of abuse and violence in there. And then, as I said, the wider determinants of health. So thinking about the structural factors that might affect that person's health or their ability to access healthcare or their ability to make various different choices about their life. So are they living somewhere where they have access to green spaces if we're telling them to go and do more exercise? Are they living somewhere where they're in a food desert and they can't access healthy food, or they can't afford healthy food, or they don't know how to prepare healthy food? So thinking about all those factors as well. And in terms of the need, so we did a study a few years ago using primary care data, so data from across a range of practices across England, and looked at women of reproductive age. So most of our work, we try not to focus just on women, but in this case, it was just women. And we looked to see, out of these women, which was over 500,000 across all these practices, how many had one of a list of about 5 lifestyle factors. So there was smoking, drinking, substance abuse, and we saw that just under 2/3 had one of these factors where they would benefit from some healthy lifestyle support. And then we looked at a short list of just 5 existing medical conditions: mental health, diabetes, hypertension. And we found that about 1/3 had at least one of those. And then you can see there's an overlap where about 1 in 4 have at least one of each of those. And that is just with a short list of a few lifestyle factors and a few conditions. So actually, from this, about 9 in 10 women had at least one factor that would benefit from some intervention before pregnancy to improve their preconception health. And of course, the other 1 in 10 would still need folic acid. So there is still something that everybody needs. And the other thing that we have done as part of the UK Preconception Partnership is really try to work with the public about what is important to the public in terms of health before pregnancy. In fact, is health before pregnancy important to the public? And so we have done, over the last few years, we have co-developed research priorities for preconception health with members of the public, men and women. And then the data them about was published last week in the Lancet. So we just had 2 more papers come out in the Lancet around preconception health. One which is looking at monitoring. It's more about the kind of the data of how we monitor, assess and monitor preconception health internationally. And the other is focusing on paternal health and its importance in preconception health. So we did this global survey and asked people a very broad question of what factors would you want in place before you or your partner had a pregnancy? Didn't mention health. We didn't mention anything. We wanted to be really open and see what people said. And it was a survey, mostly online survey, but it was free text. People could write as much as they wanted. And some people wrote a couple of words, some people wrote a couple of paragraphs. So this word cloud comes from their responses, and the words in orange are the words that were most frequently used. And you can see that health does come out as important, and that's mental health as well as physical health. But also these other factors around stability and support and finances. So yes, people are thinking about their health before pregnancy, but they're also thinking about all these other things. And if we are wanting to counsel people around their preconception health, we also need to be thinking about these other factors. So say that was an international survey, and it's just published last week. And what does it matter in terms of health before pregnancy? How does that play out? So in Britain, the most recent estimates, which are 15 years old, are that almost half of pregnancies are unplanned. And we know from the literature that unplanned pregnancies are associated with increased risks of a range of adverse outcomes. People are likely to book later into antenatal care, not come to all the appointments, increased risk of preterm birth, increased risk of low birth weight, neonatal mortality, postnatal depression. The list goes on. It goes on into breastfeeding, into vaccination uptake, into child educational and health outcomes. We also know that most of the health behaviours or risk factors for these adverse outcomes already exist before pregnancy. They're not new things that happen in pregnancy, most of them. And we also know from the first Lancet series, where we did a review of interventions during pregnancy to address diet, physical activity, these are too little, too late. You don't have enough time to make a big enough change to actually change the outcomes in terms of preterm birth or low birth weight. There's growing evidence of the importance of health before pregnancy, not just for these relatively short-term outcomes of pregnancy and neonatal, but for the long-term health of the child and for the next generation. So we know that if a person goes into pregnancy with being overweight or obese, and this counts for paternal as well as maternal, they are more likely to have a large baby who is more likely to be overweight or obese at age 5, who is more likely to be overweight or obese at an adolescent, who is more likely to be overweight or obese when they go into pregnancy. And so you set them off on this trajectory that is hard for them to then break through individual behaviour change factors. So it's thinking about the next generation and the generation beyond that and how we intervene and to break that cycle. In terms of economic costs, because often when we're talking to policymakers, we have to bring it down to the bottom line. Again, these are very old estimates, but they are the most up-to-date that we have. That unplanned pregnancies cost £400 million a year in 2010 in direct NHS costs. So that's just the either accessing care or termination services. And over £1 billion in health and social care costs in 2011. Now, obviously, that is old data. It's going to cost a lot more than that now. We've already had a little bit about inequalities, but these inequalities exist in preconception and they lead to the inequalities, or at least strongly contribute to the inequalities we see in our maternity outcomes. So here's some data. This is from maternity services data, which means it's not representative of all pregnancies. It's representative of people who book into antenatal care, and looking at 4 different preconception risk factors and seeing how common they are across different indexes of multiple deprivation. So that's like an area level measure of deprivation. And what we can see across all of these factors, and it is beyond these factors that I've pulled out here, is that the prevalence of these risk factors is higher in people who are living in the areas of the highest deprivation. And that translates into the inequalities we see in unplanned pregnancy. So this is data using the London measure of unplanned pregnancy, which is a measure I use a lot in my research. It gives you an idea of how planned or unplanned the pregnancy is on a score where 0 is the most unplanned and 12 is the most planned. These are data from antenatal services in 2 London trusts. And you can see the inequalities in pregnancy planning by ethnicity. So more unplanned pregnancies in people from a Black ethnic group. And then here, these distributions are 2 different hospitals. They serve 2 very different catchment areas in terms of their population. So the people giving birth at these hospitals are different in terms of the age of the women, the ethnicity of the women, the area of deprivations that they are living in. And you can just see that in these 2 graphs, they look different. They're showing us that there are differences in the level of pregnancy planning, people booking into these services in these different areas. And we see that then played out in our maternity, mortality and inequality. So this is from the Embrace report. And I was going to skip this slide because I saw that the person before was going to talk about it, but since you haven't had that yet, I will just briefly say, these are from the Embrace report. This one is about area of residence, and this one is about ethnicity. And again, just looking at, this is the people living in the most deprived areas, and this is people from a Black ethnic group, and seeing those inequalities all the way through from preconception health through pregnancy planning to our maternity outcomes. So preconception health can matter to reduce unplanned pregnancy and support the planning and preparation for pregnancy, improve maternal, child and longer term outcomes, and help us reverse this trend of worsening maternal inequalities. So all this work, all this evidence has led to a growing awareness of preconception health and its importance in policy. It is in the Women's Health Strategy for England that was published in 2022. It's currently being refreshed. We expect it to still feature there. And that led to, it's also in the Hatfield vision of the College of Sexual and Reproductive Health, if anyone's familiar with that. That led to it being included in the core specification for women's health hubs, which is great, awareness, but there was no further information about what that should be, who should provide it, who they should provide it to, just nothing, just included in the specification. So a great start, but people, ICB's commissioners were then like, okay, well, what do we do with that? And so the UK Preconception Partnership had a joint seminar with the Faculty of Public Health Special Interest Group on the health of women and girls, where we talked about preconception health and what was important. And we identified this gap, this lack of guidance of public health professionals and commissioners being told they needed to do something, but not really knowing what to do. And so from that came the idea to develop this toolkit. So we recruited a public health registrar to lead the work on this. And the toolkit is basically a compendium of different evidence and examples for commissioners, public health professionals, service planners, clinicians to have in one place some evidence and examples of the different things that people are doing or have done around preconception health, and how you could and support for planning what the service might look like in your setting. So I'm just going to take you through some of the information in some of the different sections. So we have a section that's about key evidence and guidance. So if you are writing a business case for a service, you can have kind of all the evidence in one place. You can go and you can pull out academic evidence, you can pull out policy to tie into the relevance there. Also some practical things. So this is from my own work, which is the really difficult thing often in preconception is how do we identify who is preconception? Because we define it as the 3 months before pregnancy often, but you already know what 3 months that was once the person is pregnant. So it's not a very useful definition in terms of identifying your population. So I've done a lot of work on how do we identify who is preconception, and I recruited 1,000 people who weren't pregnant. I asked them a load of different questions, and then every 3 months I followed them up to see if they were pregnant or not, asked them the questions again, and then I used these data to show that I could identify with very good sensitivity and specificity who is likely to become pregnant in the next year if I use the right questions. But it takes quite a lot of questions to be that accurate, and I wanted to narrow it down to actually one question that we could use. And I took that to women, and I took that to health professionals, health visitors, GPs, practice nurses, sexual and reproductive health doctors, about how could we ask these kinds of questions in which settings. And so in the toolkit, there's a summary of that evidence, of giving suggestions about in different clinical settings, how you tie preconception in to a medication review, how do you tie it into an annual disease check for someone with asthma, how do you bring it into those conversations in a way that doesn't sound like, when are you going to have children? Or, oh, you've just got married, you must be wanting to have a baby. Because those are not ways that people like to be asked this kind of question. But if you can tie it in, make it relevant so they understand why they're being asked, most people are very happy to talk about what they're thinking. And if you ask people, are you planning to get pregnant in the next year? Most people will say no to that. And actually, you will have more pregnancies in the people who said no than in the people who said yes. Because it's a very big thing to say, yes, I am planning to become pregnant in the next year. That's a very strong, certain statement. Whereas if we have a sort of a slightly softer question about how would you feel about pregnancy in the next year, you're not having to pin down an intention or specify a plan, but you get answers like, oh God, it'll be the end of the world. I'm like about to go on this massive holiday, or you get some information that can then help you support either through contraception to avoid pregnancy if they don't want, or through some preconception advice if that is on the cards for them. The next section is about assessing and monitoring. So if you're thinking about your population, how do you know how much of a need is out there? We've done a lot of work on different data and indicators for, in this one, women's preconception health, and that is available through the Office for Health Improvement and Disparities online. You can go in and you can select your local area, and then you can look at some of these factors. I've just pulled out one here, which is the proportion of pregnant women in England who took folic acid supplement before pregnancy by ethnicity. So this is maternity services data again, but you can drill it down to your population level. I've taken the whole country. And again, we can see those inequalities by ethnicity. We can also see this worrying trend that everyone is less likely to be taking folic acid before pregnancy at the moment, which is not going in the direction that we would want it to. And then also the London measure of unplanned pregnancy again. So because I've implemented this in a few different antenatal, early pregnancy and abortion settings, if this is implemented in a local area, you're able to see in your area which populations, either geographically or by other factors, are more likely to be experiencing unplanned pregnancy, where are services not meeting those people's needs, and where might we need to intervene. And if you do an intervention in terms of preconception health or sexual and reproductive health, you should see that improve through using the LMUP as an outcome measure. We've also, in the evidence and guidance, linked to lots of the information that's already out there. So we link to Tommy's, we have a case study of the Tommy's app in there, and other sources of information that is patient-facing or public-facing. And then we have educational materials for health professionals, not our own, but just pointing out where these things already exist. So there's an e-learning for health module, there's a nice clinical knowledge summary. So I say it's a compendium of bringing together things that are out there. And then we have some case studies, some examples of things that other people or other areas have done, so that people can kind of see the other things that are out there. And it ranges from like a health campaign, a social media campaign. So this one, Ready for Pregnancy, that was done in Birmingham and was translated, I think, into 11 different languages for their local area. Some work that we did again with members of the public on how to talk about preconception health with the public, because preconception health doesn't mean anything to people outside of working in the preconception health clinical or research area. So how do you talk to people about what we mean when we talk about preconception health? And then some case studies where different areas have done different things of implementing aspects of preconception care, and you can read about what they've done and think about how it's relevant to you. So the toolkit is great in the sense that it does bring all these things together. However, I would say the main limitation is that with these case studies, nobody has evaluated what they have done. So we can give you examples of things people have done, but we don't actually know if they've made any difference. So that is a big gap, and it's a problem across preconception that I think we spent a lot of time working on making the case and showing why it's important, and we're only just now getting to the stage where we're trying to implement and evaluate things. So if anyone wants to do anything, please do an evaluation alongside it. It doesn't have to be a big fancy randomized controlled trial, but some sort of baseline and end line would be really helpful. So I'm part of the NHR Maternity Disparities Consortium, and within that we have a theme on preconception and inter-pregnancy health. It's co-led between the University of Southampton and UCL, and we are working in that to take forward some of the ideas in that toolkit to implement and evaluate. We will be co-designing in different areas, so working in Bedford, Luton, Milton Keynes, in Hampshire and Isle of Wight and Northern Ireland, to develop interventions that are relevant to those local populations through an iterative co-design, implement, evaluate, refine, implement, evaluate, and hopefully start to generate some of that implementation evidence. So just to go back to the toolkit and then finish, there's a QR code at the end of this presentation that takes you to the website. It's available there. And maybe, after this, to think about what is in there that you could use in your role. What could you implement locally? What could you share back as a case study? Please evaluate it. And how can you access and use data in your area to help you with that? A final plug is that we are currently doing an international survey around what should be monitored, assessed and monitored in terms of preconception health internationally. This survey is open to everyone, members of the public, clinicians, policymakers, researchers. It's a Delphi process where we have a long list, although it is shorter than it was at one point, of potential things that we could measure and monitor for preconception health. And the idea is we'll work through this Delphi process to come up with an internationally agreed set of core indicators that could be monitored and compared across and between countries. So very welcome to do that survey if you would like. So thank you very much. I just want to acknowledge everyone who worked on the toolkit, and also to thank Kathy and Chris for the slides on the expanded carrier screening. That QR code will take you, I think, direct to the toolkit, but also that's on the UK Preconception Partnership page. If you're interested in joining, everyone is welcome. You can either email me or there's a Preconception Partnership email on the webpage. And thank you very much for your time.
My pleasure next to welcome Dr. Anna Herry. She's a consultant cardiologist at Barts and a founding member of the UK Maternal Cardiology Society. So Anna is deeply committed to improving the safety and care of women with heart disease during pregnancy, and she runs a dedicated obstetric cardiology service, educates clinicians nationally and internationally, and champions maternal cardiology. So there we go. It's a lovely introduction.
Really awkward. Sorry, it's terrible. So I'm Anna. I'm a cardiologist, and I do care about pregnancy and everything around that. This is the talk. The title I was given as "Getting It Right Before Conception." Oh, sorry. Yes. Yes. It might as well have been forewarned as forearmed. and this is what this is all about, really. We want to improve recognizing genetically transmitted conditions, so we can screen for people for the presence of these genetic variations more easily, and as such plan or help women plan pregnancy by giving good preconception counselling. I don't want to dwell on this. You all know this. Cardiac disease, one of the most is the leading indirect cause of maternal death. And if you look at the most recent Embrace report, which came out in September of last year, that only 11% of the women who died from cardiac causes were known they had a cardiac diagnosis before falling pregnant. That means these ones would have had access to preconception counselling, conventional preconception counselling. The other 89 did not, because we didn't know they had cardiac disease. But many of these women, and we've already heard about, obesity being a risk factor and all these other metabolic illnesses, were present. We just didn't pick up on them or didn't get an opportunity to talk to that. And also, maybe there was a family history for some of these conditions in some of these women who died. And if you look at the breakdown of individual cardiac causes why women died, you can see that 28% died from sudden arrhythmic death syndromes and at autopsy had a morphologically normal heart. These are difficult to predict because obviously they're sudden deaths, but maybe there's a family history. Then the other ones are about a quarter myocardial disease, cardiomyopathy, myocarditis, those kind of things. Again, many of those are inherited, and we just need to ask about that. Or once we have a woman with a diagnosis, make sure that they are aware that this may affect them in pregnancy. 9% died of aortic dissection. Now, again, a very sudden demise often, but there are a lot of familial aortopathies, and we just need to ask these questions. Is there anybody in your family who died from aortic dissection or from a tear in their aorta? And then ever increasing is the number of women who die from ischemic heart disease. That trend is up, and that's because of lifestyle factors, because of women are leaving pregnancies longer, but also are multi-morbid by the time they fall pregnant. So when you look at, the ischemic deaths, probably there's very few of them that have a genetic component to them, but a minority may well have do, and our first speaker already alluded to familial hypercholesterolemia. So if you lump all of those together, 87% of these maternal deaths potentially could have had an inherited component to them. This is a clinical vignette from the Embrace report. A woman who didn't speak English came to the UK later in life, had a normal vaginal delivery. 5 months after her baby was born, the baby died suddenly. The woman then understandably became suicidal, and the police brought her into the emergency department. She was distressed, tachycardic, hypertensive, as any mother who's just lost a baby would be. And so she also reported some chest pain, but her English wasn't so wonderful, and numbness in the hands. And they did an ECG, but they didn't really look at it very much. And they sort of went down that rabbit hole of mental health problems, which clearly she did have. She had a grief reaction, which is certainly true. She was then not further investigated, put on a mental health ward, where she died an hour later, suddenly. So what are the learning points from this case? There may have been a language barrier, which may have prevented full understanding of her history. She also had a history of domestic violence and difficult social situation. And the interpreter that was, they did use an interpreter for her antenatal visits, but the antenatal visits always occurred in the presence of her partner. So maybe that affected what she would and would not have disclosed. The focus here was on mental health in the context of the recent bereavement. The ECG was abnormal, but nobody paid any attention to it because there was anchoring bias towards that mental health issue. The biggest omission of all, in my opinion, is the fact that there was no postmortem. So surely, if the baby dies suddenly at the age of 5 months and then the mother dies suddenly, surely you'd want to know whether there was an inherited arrhythmia syndrome or something. So that was a big missed opportunity. No tissue was taken, and no family screening could have been done at this point. So genetic testing. You probably know most of this. We are mostly interested in the pathogenic and likely pathogenic mutations because they're the ones that are clinically actionable. There are some criteria for classification, what is clinically actionable, and you can find that here in this reference. And once there is an affected family member who has a genetic diagnosis, we can then start cascade screening and predictive genetic testing. If your heart looks like this, i.e. you have a phenotype, you don't really need to screen if there is a family member with that mutation already. Why is this important for this context? Well, we can offer pre-implantation genetic testing for conditions that are caused by one gene. The NHS will fund pre-implantation genetic testing if the risk of the affected pregnancy is more than 10%. So in somebody with hypertrophic cardiomyopathy, for example, autosomal dominant inheritance, 50% of the offspring will carry that gene. The mother must be below the age of 40. The BMI must be between those, which can cause problems because some of our Turner's ladies, for example, are tiny and they have a BMI below 19. So they can do whatever they want. They will not be referred for PGT on the NHS. That's a big problem. Also, if there is one living unaffected child from that same relationship, the NHS will not fund PGT. These are some examples. This is not exhaustive, but just to give you an idea of what sort of conditions are approved for NHS-funded pre-implantation genetic testing. So lots and lots of the cardiomyopathies. Then the channelopathies. Channelopathies are those that cause sudden arrhythmic death syndromes like Brugada syndrome or long QT, for example, which was suspected in that clinical vignette that I just showed. Aortopathies and then metabolic diseases, really rare, but easily preventable or treatable once known. So Anderson-Fabry disease is one of them. And this is an example of a family tree where this is the mother who has the condition. She's got dilated cardiomyopathy, 68 years old. She's had lots of rhythm problems, so she's got a nasty arrhythmogenic type variant. And she has passed on the gene to her 32-year-old daughter, who does not have the phenotype. So all her cardiac tests are normal. Should she be offered pre-implantation genetic testing? She's got a normal heart. Yes, she should be, because she can pass that gene on. And who knows if at the age of 40, she starts developing the phenotype. And by the time she's 68, she might look just like her mother. So the next two, I've got two case examples I want to show you, which illustrate what this sort of preconception testing could look like, or maybe where it didn't look like and could have looked like. Anyway, so this is the story of a young woman, a primate, normal body weight, nothing very much exciting. She didn't speak much English, so there seems to be a theme here. At 34 weeks, she saw her midwife and was referred to triage for slightly increased blood pressure. So there was a suspicion she might develop preeclampsia, but all her tests remained negative. And so she then reappeared in labour to the midwife-led unit at term. Her blood pressures were increasing, maybe because she was in pain. It's mainly systolic elevation here. So again, urine was negative. She was transferred to the labour ward for an epidural to deal with that pain and management of her blood pressure. Again, nothing to suggest she had preeclampsia. The only thing that was abnormal was her temperature was a little bit up. They did a septic screen, which was later found to be negative. She gave birth vaginally with minimal blood loss and good outgas scores. She was then transferred to the postnatal ward for blood pressure monitoring and repeat her preeclampsia bloods. An hour after she gave birth, she became unresponsive and crashed. So she stabilized with fluids. Her blood pressure remained slightly lowish, but she came round, and then it happened again. So there were a few episodes where this woman became symptomatically hypotensive. At this point, they thought maybe best to stop the labetalol. She complained of chest pain, but that settled. 5 hours postpartum, she had more chest pain, which then radiated to the left shoulder. Her saturations were dropping, her blood pressure was low, she was tachycardic, she was put on oxygen, and they requested an ECG and a chest X-ray. Those of you who are used to looking at ECGs will agree that this looks grossly abnormal. There's widespread ST depression, maybe even a hint of ST elevation there, and her chest X-ray clearly shows pulmonary edema. 6 hours postpartum, she gets a medical and critical care outreach review. She still has chest pain. She has said ECG changes. She's in pulmonary edema with increasing oxygen requirements. She's tachycardic, hypotensive. She is then moved to the intensive care unit where they suspect this could be peripartum cardiomyopathy because after all, she's 6 hours postpartum, or maybe an aortic dissection. By 8 hours, she's tubed, ventilated, in cardiogenic shock on the intensive care unit. Her ECG changes are evolving. She has now got Q waves in her ECG. Troponin is up at this point, and she's in failure, so BNP is also elevated. She doesn't have an aortic dissection. She does have gross wall motion abnormalities on her ECG. Can you see the basal part of her septum is contracting normally, as is the lateral wall, but the distal septum, the apex and the lateral wall are not moving. Somebody looked in her East London patient record and found that at some point in the past, she had a cholesterol of 12.5 with an LDL of 11, and somebody commented that this was probably familial hypercholesterolemia. At this point, they clocked. She is probably having an infarct. She's treated as an acute coronary syndrome, transferred to the cardiac center for urgent angiography. These are her coronary angiograms, and you don't need to be an interventional cardiologist to see that you can't see anything. So this is diffusely diseased. This is what should have been her right coronary artery. There's hardly anything there. This is blocked in the mid-segment. With the eye of faith, look here. This is the left main stem. She's got a tight stenosis of her left main stem and disease in the LAD and the circumflex. And you can see they've already put a wire down there because they want to do something about it. So when they inflate the balloon in her left main stem, she crashes, loses output. And as they are doing the procedure, they put a stent into her LAD here. As they are proceeding, it says sign in now, please. So the procedure was very challenging because they just couldn't stabilize her. She kept losing her output. She was really, really sick, tried to die on multiple occasions, so much so that they put her on ECMO. And despite ECMO being established, they still couldn't stabilize her. So they got onto the phone and called our local transplant center, where she was accepted for transfer the same evening for consideration of a biventricular assist device and transplant assessment. Over in the transplant center, they put an impeller in. It's one of those little rotational pumps that they stick into the apex of the left ventricle, and you can increase or decrease the rotations per minute to produce a constant cardiac output. And with that, she stabilized quite well. They decided they might as well give her a full metal jacket and attempt to revascularize that awful-looking right coronary artery as well. She spent 11 days in the transplant center and stabilized. She came off all support and was assessed for a transplant. At this point, they thought there's no contraindication for a transplant, but actually she has stabilized enough so she doesn't need one now. So please go back to where you came from. I just want to show you, this is the pre and post right coronary artery. And you can see it's lined with stents all the way down, but you can see that there wouldn't have been much going through before that. So on repeat echocardiogram, her left ventricle remains severely impaired with evidence of a large anterior infarct. Her dyslipidemia was addressed with maximum aggressive treatment, and blood was sent for genetic testing. You wish it would have been done sooner. She was reviewed by one of the midwives who made sure that she did not go home without a contraceptive implant. and she was referred to the Birth Reflections Clinic because obviously that must have been pretty traumatic for her. She was referred for a cardiac MRI to assess just how much of that heart muscle was still alive, and she was also listed for a subcutaneous ICD for primary prevention because her left ventricle was so poor that she was at risk of dying of arrhythmia. This is her MRI scan, slightly easier on the eye than the echo was. You can appreciate that distal septal wall motion abnormality, the apex, the lateral wall gone, and you can see the white bit is where the gadolinium hangs around in the dead tissue. So the black is the normal heart muscle, and everything that's white is gone, and you can see again here the anterior wall motion abnormality around the entire apex, and even where it's still moving, there is subendocardial scar from probably that episode or multiple episodes of profound hypotension where nothing was going to her heart muscle. Of course, her genetic test came back positive for familial hypercholesterolemia, and so now cascade screening can commence. So what are the learning points from this case? There was a missed opportunity in primary care that should have prompted a referral to the cardiovascular prevention clinic, which then would have triggered genetic testing most likely. The second missed opportunity is that delay in her treatment for the acute massive infarct that she had. So while they contemplated peripartum cardiomyopathy, we have to remember this is a diagnosis of exclusion. And the history, the ECG and the echocardiogram all suggested that this was coronary pathology. We need to remember that pregnant women are 4 times more likely to have a heart attack than the same woman with the same constellation in the non-pregnant state. Once her diagnosis was established, her personal individual risk can be addressed, but also family testing can commence. That's the first case. The second case is very different. So this is a young girl who arrived in the back of a lorry from Vietnam as an asylum seeker. She complained to her GP of palpitations and shortness of breath and was referred to my general cardiology clinic. She came to clinic with an interpreter and a social worker and told us that she had long-standing shortness of breath and recently had a near fainting episode after running for a bus. She was not overweight, quite comfortable, and on examination I found an ejection systolic murmur. So I thought, let's do an ECG and an echo. And if you're used to looking at ECGs, the diagnosis is pretty much there. There's lots of voltage, so lots of probably hypertrophy with strain pattern on her ECG. So I thought she must have hypertrophic cardiomyopathy, which was confirmed on her echocardiogram. A normal septum is about 1 centimetre long, like this. Hers is about 2.5 centimetres. And in the short axis, you can see that asymmetric hypertrophy of her septum here. So this is a new diagnosis of hypertrophic cardiomyopathy with left ventricular outflow tract obstruction, which is relevant because when she exerts herself, she cannot increase her cardiac output. So we explained that to her, and I referred her to the cardiomyopathy clinic, made sure she had contraception in place, and asked her, just planted that seed in her mind that should she ever consider starting a family, she should please come back for some preconception counselling. In the cardiomyopathy clinic, she had a risk assessment, which was relatively low for sudden cardiac death as a result of all these investigations. She was referred for genetic counselling and genetic testing. And this is her MRI scan. You can see, again, really, really thick septum. And interestingly, this hypertrophic cardiomyopathy affects both ventricles. You can see the apex of the right ventricle also really, really thick. This is a post-gadolinium, post-contrast study. You can see the diffuse increase in signal here, which tells us that it's quite a lot of fibrosis and scar in that heart already. Her genetic testing came back positive for a myosin heavy chain mutation, which is known to be pathogenic. A year later, she tells the cardiomyopathy doctors that she has now met a suitable partner and they are thinking of starting a family. So she's referred back to me for preconception counselling. I explained that 50% of her babies have a theoretical risk of inheriting her condition. PGT was offered. She didn't want that, which is fine. And I was then arranging for her these tests to assess her preconception risk. So left ventricular outflow tract gradients tend to go up in pregnancy, and so does pulmonary artery systolic pressure because of the stiff ventricle that gives back pressure into those lungs, which can cause problems in pregnancy. To a cardiologist, pregnancy is like 9 months on the treadmill, really. And I said to her, please let me know as soon as your pregnancy test is positive. She was given contact details, and of course she did. And by the time she was pregnant, as expected, her left ventricular outflow tract gradient had gone up. She was a bit breathless but stable. We looked after her in the multidisciplinary pregnancy heart team. At 32 weeks, we planned her delivery and decided she could have a normal vaginal delivery, which is the default position, contrary to urban myth that states every woman with a cardiac problem needs to have a cesarean section. We advised an early epidural to minimize the catecholamine drive, which could trigger arrhythmia, and careful fluid management. She could have oxytocin as long as it was given over a longer period of time as an IV infusion rather than a big bolus. And I put her observation chart from the peripartum period in her just to illustrate. All the right people were in the room for her birth. We were well prepared. We knew what was coming. She arrives in labour. Her blood pressure is normal at around 130 systolic. Pain drives it up to about 150. The epidural goes in here. And as expected, the blood pressure drops a little bit. The minute it hits T4, which is where the sympathetic innervation sits, her blood pressure drops further, which is counteracted by our very experienced cardiac obstetric anaesthetist. Blood pressure comes up again. Here she delivers, oxytocin is started, blood pressure keeps dropping, then she vomits, as they all do, with the oxytocin, becomes really vagal, her blood pressure is now 70, and again, as the obstetric anaesthetist brings it up again with a little bit of good medication, I think it was metaraminol. So she was as safe as she could have been, and yet this is such an unstable time, and if you look at what happens to hemodynamics in the peripartum period, you can see why that would have happened. The uterine contractions, autotransfusion, blood loss, systemic and pulmonary vascular resistance changing once the baby is out and so forth. So the learning points from this case is that we got it right here in this one. She had contraception in place until all her investigations and the preconception counselling were complete. She was offered PGT. Her antenatal care was delivered through a multidisciplinary pregnancy heart team who also planned her delivery. It was as safe as it could have been, and by the time she was leaving the maternity unit, she had follow-up with her regular cardiomyopathy team. She now has a subcutaneous ICD, you'll be pleased to hear, and I think she's had another child since. That takes me to the idea that we need to move away from thinking of women only around pregnancy. It starts with menarche, pretty much. From when they have periods, they're technically preconception. I know that doesn't fulfill the criteria that we've been given earlier, but we need to think about this. We need to start screening before they fall pregnant so we can put all these measures in place for them. We need to, once they are pregnant, we need to risk assess them at booking. Do ask these questions. Is there anything in your family? And if there is anything to suggest they've got cardiovascular disease, please refer them to the pregnancy heart team or whatever urgent pathway you've got in place. So we need to improve recognition of these conditions. We need to carefully delivery plan them, make sure they've got follow-up in place. And then postpartum is the new preconception. They're likely to do it again. So inter-pregnancy health is really, really important. This is sometimes the only opportunity to address risk factors. And also, once the family is complete, to think about long-term cardiovascular and metabolic health. And this is the new recommendation that came out of the Embrace report, which is basically saying that get ready for pregnancy. And once you are postpartum, you are technically preconception again. So do whatever you can to optimize your health in between pregnancies and beyond. So I'd like to thank you with that. And with a shameless plug for our lovely and friendly club, the UK Maternal Cardiac Society, we're a multidisciplinary society of people interested in looking after women with cardiovascular disease in and around pregnancy. Some resources here if you ever need them. And that's me done.
Hello, I'm Claire. I am an inherited arrhythmia nurse by background. Most of my preconception counselling work has been in looking after families with inherited arrhythmias and arrhythmogenic comorbidity. So that's where kind of a lot of my case studies will be. I'm going to briefly just cover what the inherited cardiac conditions are and then really come in and focus on a patient story. I have a video from one of my patients, Claire's in this conversation, and then go through a survey. So for the talk today, I really wanted to bring in the patients' voices who have been through and given birth for the talk today. So basically, inherited cardiac conditions are either a big heart, a big lumpy aorta, or an electrical heart condition. In terms of their way through the through diagnosis, kind of the main take-home points are some people may present with no symptoms at all and picked up through family screening. And that might be that the relative has been picked up in life, or sadly that they've died suddenly and then family members have come in for screening. It might be that some people do present with symptoms, and that can again vary from very mild symptoms that happen quite intermittently with palpitations. But again, it might be the other end of the spectrum and someone presents with a cardiac arrest. Everyone's experience within a family is very variable and varies significantly. When going through preconception counselling, this will have a bearing on how they perceive their heart condition, their risk to them and their risk to baby, which in turn may impact how they decide to conceive and screen their child. Once the diagnosis of an ICC is made, stable patients are then moved to an open follow-up. And this is happening much more readily within ICC clinics. So a lot of these men and women are now out in the community and don't have regular follow-up. So just to say that if we do ask that they refer themselves back with at least 2 years' notice so that we can go through preconception counselling when they are starting to think about starting their own family. So the survey I sent out to anyone who had had a baby with an inherited cardiac condition in the team. I sent it out in preparation for so there's not high degree of rigour here. Unfortunately, no men replied to me. So the age that our respondents started to think about having a family was between 18 to 34, so slightly younger than I had expected. 2/3 were still under their inherited cardiac conditions team, with 1/3 already out in the community and needing a referral back into clinic. And just be aware that as services are trying to move everyone to an open follow-up, this will happen much more readily. Most of our respondents had received preconception counselling, either through the inherited arrhythmia nurses or through Dr. Harry and her team at Bart. Two-thirds of our respondents had had a gene change picked up responsible or causative of their inherited cardiac condition. When there is a gene change, then we can talk through the option of pre-implantation genetic testing and also prenatal genetic testing, with the option of doing a chorionic villus sampling or an amniocentesis once pregnant. This is quite a hard part of the preconception counselling, because you then say to them that you then have the option to terminate that pregnancy, which, when you're bearing in mind the very broad range of presentations of people with inherited cardiac conditions, that can really take some families by surprise. I try and phrase it what's your thoughts on having a baby with the same gene change as you, and really trying to get to the bottom of it that way. But I have had some parents say, so you're telling me I would be terminated? And it's really juggling that information and making sure that they know what options are available to them. I can't predict which ones that they will go for. That's part of why I love doing what I do, because you're working with them as a couple to get them to the point that's making a decision that's right for them. But it is giving them that information, and hopefully in as neutral a way, without kind of labeling one option or the other. If they decide to conceive traditionally, then again, if they do have a gene change, we can talk through about cord testing. And if baby then doesn't have it, then we can reassure and discharge and don't have to keep screening and following up baby. I asked them about what they wanted before they had preconception counselling. What was it that they most wanted to know about? And most of them said what was the condition, especially for the partner who may not know much about it, what the risks were to mum and to baby, as well as the maternal health risks and the conception options available to them. When asking about their concerns and what worried them most, again, kind of risk to mum and to baby, it might also be we talk through about how we monitor mum during pregnancy. That might be more echoes if they have a structural heart problem, but if it's an electrical heart problem, maybe more Holter monitors. For long QT, the risk is higher in the postpartum phase, and that area seems to get forgotten about because they've already come out of maternity services by then. And also they most wanted to know about whether they could give birth locally, which again, Claire highlighted in her talk. A lot of the families, although they come to ICC services at Barts, might live as far away as Norfolk. So again, that is a really important consideration. In terms of what we covered, I've spoken about quite a bit of it already, but I just want to draw your attention to the first and last point. I always go through and ask them how they were diagnosed and go through the family history to see whether someone has a very high risk or has had a very tumultuous journey if someone has died suddenly, because that may then change how they view the risk to them and risk to baby. I also use it as an opportunity to ask them how emotionally and psychologically they've dealt with and coped with their diagnosis. That may have been made when they were born, it might have been made in childhood, and you kind of then just get on, or something that mum always did, but now you're at the point where you're going to perhaps start having your own family. Maybe that's a good point to just stop and take a breather and say, actually, now I need to deal with this and make sure that I'm okay with my diagnosis before we start bringing children into the mix. We would always support and a couple's choice to carry their own children, but I do also talk about adoption, fostering and sperm donation. Was your heart condition taken seriously by the maternity and obstetric healthcare professionals? Overwhelmingly, yes, which is brilliant to hear. I would just say again, the bottom point, the lady saying she had to repeatedly raise that they prescribed me medication that was on the list of drugs to avoid. This happens time and time again. People with Brugada and long QT each have a separate list of drugs to avoid, and this happens across healthcare. It's not just maternity, but they end up getting prescribed a drug that's on that list. For some, they're really kind of what seem like a benign medication. It might be a proton pump inhibitor or an antibiotic, but for some people, it can cause them to have a cardiac arrest. It is to be taken seriously. Again, overwhelmingly, when we asked at what point should we start talking about preconception counselling, and they said as early as possible, even just in small bits of information, just drip feeding that information through. If they're picked up in childhood and they're under grade trauma 3, starting it then, as Dr. Harry said, once they're starting to menstruate, they can start to have children. So just having that time to think about actually what having a baby through pregnancy will be like. So in summary, just ask your patient about their family history. Have they got a family history of sudden cardiac death or inherited cardiac conditions? Some family members, when someone does die suddenly, then won't go for screening. They're just too busy for many reasons, focusing on their grief and what that means for the family in the immediate wake of that. So don't come and have screening. And maybe at this point, it is, again, when they're starting to think about their family, it's a tipping point for them. Talk about preconception, even when young, and listen to our patients. And I just want to thank Claire, who did the video, and to all the patients who completed the survey.